Hello everyone, my name is Laura Wood. I'm an Associate Professor of Pathology and Oncology at Johns Hopkins University, and today I'm going to talk about pancreatic ductal adenocarcinoma and its variants. I want to thank the Pancreatic Biliary Pathology Society as well as PathCast for the invitation to come and speak with you all today. So there are several clinically important morphological variants of ductal adenocarcinoma that we'll discuss today, but we'll start with the most common variant, which is tubular or ductal carcinoma of the pancreas. So we're going to start with kind of typical ductal adenocarcinoma, which I'll sometimes refer throughout this presentation as PDAC, short for pancreatic ductal adenocarcinoma. So the general morphological pattern of tubular carcinoma is neoplastic glands and a fibrotic stroma. And with this in mind, the major histological differential diagnosis is chronic pancreatitis. So to start with, we'll talk through several morphological features that can help you distinguish the glands and stroma in chronic pancreatitis from the glands and stroma of ductal adenocarcinoma. So the first feature that we'll discuss is the haphazard arrangement of the neoplastic glands in pancreatic ductal adenocarcinoma. The glands invade without respect for architecture, the regular architecture of the pancreas. So you really have glands that are haphazardly arranged, invading throughout the fibrotic stroma. Here's another example of this haphazard arrangement of glands. And this is really in contrast to chronic pancreatitis, where you have a retention of the lobular architecture of the pancreas. And you can see in this example, in the middle of this slide, there are areas where you have, because of acinar atrophy, glands or ducts in the middle of a fibrotic stroma. But when you look at it at lower power, you still have retention of that lobular architecture. And so this is chronic pancreatitis rather than pancreatic ductal adenocarcinoma. So keep in mind that pancreatic ductal adenocarcinoma has a haphazard arrangement of the neoplastic glands and does not have preservation of the lobular architecture like you see in chronic pancreatitis. When we look at higher power features, the glands in pancreatic ductal adenocarcinoma often have incomplete lumina, meaning that rather than a lumen that's surrounded on all sides by epithelial cells, you have parts of the gland that don't have an epithelial lining, and this is often seen with luminal necrosis or necrotic debris, dead cells in the lumen of the gland. Here's another example of a gland of pancreatic ductal adenocarcinoma with an incomplete lumen and associated luminal necrosis. Here's another example. This gland of this ductal adenocarcinoma has a complete lumen, meaning the gland is fully lined by neoplastic cells, but it has really pronounced luminal necrosis in the middle of this gland, a lot of necrotic debris. One final example of a gland of pancreatic ductal adenocarcinoma with luminal necrosis or necrotic debris in the middle of the gland. So there's often pronounced nuclear atypia in pancreatic ductal adenocarcinoma. So you see nuclear size variation in the glands where you have a mixture of smaller, blander nuclei and very large atypical nuclei. We often say that we should see a nuclear size variation with a ratio greater than 4:1, meaning that within one gland you have some nuclei that are 4 times bigger than other nuclei. And here's an example of this in this gland. You can see that there's some small nuclei and some really large. And here's another example, again, scattered really large bizarre nuclei in the same gland with smaller nuclei. Now, in addition to these, kind of features of the glands or the cytology, the relationship of the glands or the ducts to other structures in the pancreas can help you distinguish pancreatic ductal adenocarcinoma from chronic pancreatitis. Having glands next to muscular arteries is highly suggestive of pancreatic ductal adenocarcinoma, that these glands are malignant, because in chronic pancreatitis, the gland should be nowhere near the muscular arteries. And this is an example. You can see the muscular artery in the middle, and the glands next to it are quite bland cytologically, but their location really indicates that they are malignant glands rather than benign because they're next to this big muscular artery. Here's another example, again, the muscular artery in the middle of the image with the glands next to it. And again, these are very benign, or not benign, sorry. They're very bland, well-differentiated glands. So cytologically, they're not really impressive, but really the location of these glands next to the muscular artery tells you that these are malignant glands of pancreatic ductal adenocarcinoma. And here's one final example. The cytology of this gland is less subtle, with a lot of, loss of nuclear polarity and nuclear atypia and structural features, but it is right next to a muscular artery as well. And I think that architectural alteration helps you to confirm that this is a gland of pancreatic ductal adenocarcinoma. And just to highlight that in chronic pancreatitis, where you have preservation of the architecture of the lobules, the muscular arteries are at the periphery, whereas the ducts are in the center. And so in chronic pancreatitis, you should never have a benign gland next to a muscular artery. Now, in addition to the glands being next to muscular arteries in PDAC, you can also have malignant cells actually invade and have vascular invasion. So the malignant cells go into the lumen of the blood vessel. One challenge with identifying this is PDACs in particular, when they invade into vessels, they often replace the endothelium and colonize the wall of the vessel. So you have circumferential involvement of PDAC along the lumen of the vessel. And it can be easy to mistake that for either just a gland of cancer or even a pannon. And so what can help you here are two things. One is the architecture of the surrounding structures. So in this, you have a large artery on the left, and then the PDAC is actually involving the adjacent vein. And what tells us is that this is the vein is that you can see the retained smooth muscle kind of around the wall of this cancer. So this is a PDAC that's involved a large vein, but it has colonized the wall of that vein and replaced the endothelium. This is another example of a PDAC that has invaded into a vein and colonized the wall and replaced the endothelium, and we can still tell this is a vein by the smooth muscle cells that surround it. Sometimes the cytology of the cancer cell involving the vein are quite bland and can even mimic pannon, so pancreatic intraepithelial neoplasia. And this is a nice example of that, where cytologically the cells are quite bland. We don't see a ton of atypia, but we can actually see that there is surrounding smooth muscle. And so what tells us that this is a vein would be the architecture, the location of it in the pancreas, and then also the smooth muscle surrounding this blood vessel that's been invaded by PDAC. Here's one more example. Again, very bland cytologically. You would think this is a pannon, but then when you kind of look at where it is, it's surrounded by smooth muscle. You can do an elastic stain and appreciate the elastic lamina of the blood vessel that this PDAC has colonized. So again, with vascular invasion in pancreatic cancer, it's important to remember that you don't always see it as detached malignant cells in the lumen of the vessel. The cancers often colonize the wall of the vessel, and that can mimic a gland of cancer or even a pannon. And so you have to keep in mind the architectural landmarks of where the blood vessel should be, as well as the retained structures of the vessels, like the smooth muscle wall or the elastic. And Desmond staining and elastic staining can be helpful in equivocal cases to really convince yourself that this is pancreatic cancer involving a vessel. So pancreatic cancer, in addition to vessels, can also involve nerves, and seeing these malignant glands involving nerves can help convince you that this is a malignant process. In this case, you see the nerve on the right-hand side, and then the gland of cancer that's involving the nerve sheath. Another example with the nerve on the bottom and the malignant glands involving the nerve on top. And this, I put in this image to remind us that you often get these nerves cut in different tissue planes, and so sometimes you get cut along the long axis, and so you see the long side of the nerve and then the gland kind of involving that whole long side. So unfortunately for us, all glands and nerves are not malignant. It is possible quite rare but possible to have benign glands in a nerve, and particularly in the setting of longstanding chronic pancreatitis. And so very bland glands in a nerve with no other features of cancer can still be a benign process. In equivocal cases, immunohistochemistry for SMAD4 can be helpful to distinguish benign from malignant. So SMAD4 is a gene that's commonly mutated in pancreatic cancer and ductal adenocarcinoma. It is either altered by homozygous deletion or an activating mutation, which frequently leads to loss of protein expression that can be assessed by immunohistochemistry. This genetic event is a late event in the progression of pancreatic adenocarcinoma, and so SMAD4 expression is retained in normal pancreatic ducts and acini, also in low-grade pannin and in stromal cells, so you tend to have a good internal control. And so immunohistochemistry for SMAD4 can be really helpful for confirming an impression of pancreatic ductal adenocarcinoma. Here are two examples of SMAD4 mutated pancreatic cancers that show loss on immunohistochemistry. On the left, you can see a gland with SMAD4 loss admixed with stroma that retains expression of SMAD4, so a good internal control for the antibody. And on the right, you can see a few scattered benign glands that retain SMAD4 expression, and then on top of those glands, you can see much more atypical, poorly differentiated carcinoma that's lost SMAD4 expression. And when interpreting these SMAD4 immunohistochemical stains, it's important to remember that these are, inactivating genetic alterations or homozygous deletions, so they should lead to complete loss of protein expression. So it's not decreased expression, but it's true loss of SMAD4 expression. Here's one more example. Again, a very bland, well-differentiated gland, but with total loss of SMAD4 expression. So this is a gland of pancreatic ductal adenocarcinoma. One important caveat in interpreting SMAD4 immunohistochemistry, though, is that SMAD4 is only lost in about half of PDACs. And so the loss can really help you to confirm a malignant diagnosis, but half of PDACs are going to retain SMAD4 expression. So if your cells in question retain SMAD4, that doesn't necessarily mean that they're benign. So again, to summarize our features that support the diagnosis of adenocarcinoma, a haphazard growth pattern of the glands that doesn't respect the architecture of the pancreas, having incomplete lumina or luminal necrosis, having nuclear pleomorphism with size variation with greater than fourfold alterations in nuclear size within one gland, having growth next to a muscular vessel, invasion of surrounding structures like perineural invasion or vascular invasion, and then finally, immunohistochemistry for SMAD4 loss can be helpful for confirming an impression of a malignant neoplasm, but retention of SMAD4 does not mean that it's benign. So after bringing up SMAD4, I want to talk briefly about the genetics of pancreatic ductal adenocarcinoma, focusing on what is clinically actionable at this time. So there are 4 genes that are altered in a large proportion of PDACs, and these are the oncogene KRAS, as well as 3 tumor suppressor genes, CDKN2A, which is also known as P16, P53, and SMAD4. And SMAD4 we just discussed as an immunohistochemical marker. Aside from that IHC use of SMAD4, though, none of these 4 genes are clinically actionable. They don't impact patient therapy. However, there are other less frequent alterations in PDAC that may be targetable. The most important of those right now are alterations in BRCA1, BRCA2, and PALB2, which lead to defects in DNA double-strand break repair. And because of these defects in DNA repair, these tumors respond really well to platinum chemotherapy and also PARP inhibitors. So the alterations in BRCA1, BRCA2, and PALB2 are most commonly germline, though they are occasionally somatic. The other alteration to keep in mind, rearrangements in KRAS wild-type PDACs, like some involving genes like NRG1 and NTRK. These can be targetable with kinase inhibitors, so they're quite uncommon, but they make a big difference for the patients who have them. And so for these reasons, the NCCN currently recommends germline testing for all PDACs to identify these tumors with defects in double-strand break repair for platinum and PARP inhibitors, and then somatic testing for metastatic and locally advanced to identify other potentially actionable subsets. This is an evolving field, though, and it's possible as more targeted therapies are identified in the somatic genome, the recommendations will be broadened. Many academic centers right now do the somatic testing on all PDACs, but that's not something that's been widely recommended by advisory panels. I want to just briefly touch on the ability or the attempts to classify PDACs based on transcriptomics. There have been a lot of papers on this. In the more basic science literature, a lot of different classification schemes that have been proposed, and it's all been kind of distilled down into two groups. One that is more classical or epithelial, and another that's more basal or mesenchymal or squamous. So there's kind of an attempt to do a binary classification. These do seem to have some implications on prognosis and propensity to metastasize, with the basal tumors having a worse prognosis and being more prevalent to metastasize. But right now there's not clinical decisions that are made based on this classification, but it is a rapidly evolving field. So with all that background on pancreatic ductal adenocarcinoma in mind, I want to move on now to talk about the variants of PDAC that are morphologically, clinically, and molecularly distinct. So the first one I'll talk about is adenosquamous carcinoma. Adenosquamous carcinoma is a malignant epithelial neoplasm that has significant components of both glandular and squamous differentiation. An important point here is that pure squamous cell carcinoma of the pancreas is very rare. So if you have a lesion that looks exclusively squamous without a glandular component, it's important to always exclude a metastasis. To call something adenosquamous, the squamous component should comprise at least 30% of the neoplasm. And the squamous component can express markers of squamous differentiation on immunohistochemistry, such as P63 or P40. P40 is likely more specific for squamous differentiation, so that's the one that we use in our practice. Adenosquamous carcinoma is an aggressive neoplasm. The median survival is only 6 months, with few patients surviving beyond a year. So these have a very poor prognosis. I want to just show some histologic examples of adenosquamous carcinoma. In some cases, the two components are quite separate. These are two images from a single slide of adenosquamous carcinoma of the pancreas. And on the left, you can see a region with a glandular adenocarcinoma morphology with these malignant glands and a very fibrotic stroma. And on the right, which was a few millimeters away from what's on the left, you can see an area with clear squamous differentiation. You have these cells with abundant eosinophilic cytoplasm, prominent intracellular borders, and you even have focal keratinization. And so the squamous component was more than 30% of this neoplasm, and so this is a good example of adenosquamous carcinoma. Sometimes the components, the glandular and squamous components, are more intimately intermixed. In this example, you can see on the right, there's a malignant glandular component, and then on the left, a component that looks more squamous. For this one, we wanted to prove it with immunohistochemistry. So we did a P40, which is shown here. And you can see that the squamous component on the left has really strong nuclear labeling for P40, indicating squamous differentiation, and that's negative in the glandular component on the right. Here's another example of an adenosquamous carcinoma. In this one, the squamous component is on the right, again with the eosinophilic cytoplasm and focal keratinization. The adenocarcinoma component, rather than being gland forming, was more poorly differentiated but had cells with intracytoplasmic mucin, as can be seen on the left-hand side. In this final example of adenosquamous carcinoma of the pancreas, this one was mostly squamous and just had some scattered cells with intracytoplasmic mucin, but still this is an adenosquamous carcinoma. So the genetics of adenosquamous carcinoma, these have similar alterations to PDAC with KRAS, P16, SMAD4, and P53. They may have alterations in MYC target genes as well. One interesting point is there were previous reports of highly prevalent mutations, somatic mutations, in this gene UPF1, which is involved in RNA nonsense-mediated decay, but then other papers came out expressing controversy over whether these are somatic drivers and suggesting that these may just be non-pathogenic germline variation. So I think there's still a fair bit of controversy over the role of UPF1 in adenosquamous carcinomas. These do, with regard to the transcriptomic classification, these adenosquamous carcinomas fit in the basal-like group. There are immunohistochemical stains that can help to classify based on transcriptomic signatures, and GATA6 negative does push them into the basal-like group. Again, not clinically actionable right now, but may be important in the future. As far as therapy of adenosquamous carcinoma, inclusion of a platinum agent in the adjuvant regimen improves survival, and so the presence of a squamous component can alter chemotherapy, so it's important to report these accurately. So we'll now move on to colloid carcinomas. Colloid carcinomas are an infiltrating adenocarcinoma characterized by mucin-producing neoplastic epithelial cells that are suspended or floating in large pools of extracellular mucin. To call something a colloid carcinoma, the colloid component should comprise at least 80% of the neoplasm, and these have a very characteristic gross appearance, which I'll show some images where these are soft and gelatinous with thick tenacious mucin. They're almost always associated with an intestinal type intraductal papillary mucinous neoplasm, or IPMN, as their precancerous lesion. And these have an improved survival rate compared to standard PDAC, with a 5-year survival rate approaching 60%. Here's a beautiful gross image of a colloid carcinoma from Ralph Ruban, and this shows this gelatinous texture and this with pools of thick tenacious mucin that are even visible grossly. Another gross image from Ralph Ruban, again showing a more focused image on a colloid carcinoma, again with these pools of gelatinous mucin. And with that gross appearance, it's not surprising that the microscopic appearance shows these large pools of mucin with epithelial cells floating in them. Occasionally, rather than the epithelial cells floating in the mucin, they're kind of lining the spaces with the mucin, as in this case. And here's a slightly higher power version of that, where you can see the malignant epithelial cells are lining the spaces filled with mucin. Here's a higher power version of some smaller pools of mucin with the malignant epithelial cells of the colloid carcinoma, both floating in and lining them. The cells floating in the mucin, they can float as groups of cells or as single cells, and they often have intracytoplasmic mucin, as well as the mucin pools that they're floating in. The cytology of the cells in the mucin can vary quite a bit. This one had more eosinophilic cytoplasm, but again, what makes it a colloid carcinoma is this architecture of, large pools of mucin with neoplastic cells floating in. And then finally, you can have areas of signet ring cell morphology within colloid carcinomas. So here, these cells, discohesive single cells with a large vacuole of intracytoplasmic mucin that indents the nucleus. So these almost all colloid carcinomas arise from intestinal type intraductal papillary mucinous neoplasms, as seen. This is an IPMN without a colloid carcinoma. And then here is a different area in that same case, where on the right we see the intestinal type IPMN, and then on the left you can see the pools of mucin that are lined by malignant epithelial cells. So this is a colloid carcinoma arising from an intraductal papillary mucinous neoplasm. One important point to remember when evaluating intraductal papillary mucinous neoplasms is that acellular pools of stromal mucin can be seen in non-invasive IPMNs. And so to call something a colloid carcinoma, you really have to have the neoplastic epithelial cells either floating in the mucin or lining the mucin-filled spaces. And so in this case, you have an intraductal papillary mucinous neoplasm on the left, and then on the right, you can see the pools of mucin, but all of the cells in these pools of mucin on higher power are inflammatory cells, and there are no neoplastic epithelial cells. Here's another example of pools of extruded extracellular mucin in the stroma next to an intestinal type intraductal papillary mucinous neoplasm. And again, without epithelial cells, these are not colloid carcinoma. These are simply extruded mucin in the setting of an IPMN. And the mechanism for this is likely, IPMN rupture with some mucin that gets out into the stroma, but these are not colloid carcinoma unless they have malignant epithelial cells associated with them. So immunohistochemically, colloid carcinomas follow their intestinal differentiation. They express CK20, CEA, MUC2, and CDX2. MUC1 is typically negative. This diagnosis of colloid carcinoma, though, is based on the architecture of the cancer, and you don't necessarily need the immunohistochemistry to confirm. Genetically, colloid carcinomas follow the genetics of intestinal type IPMNs. So they do have KRAS mutations and P53 mutations like standard PDACs, but they also can have mutations in GNAS and RNF43, which are more specific for the IPMN pathway. So we'll now move on to talk about hepatoid carcinoma. Hepatoid carcinoma is a malignant epithelial neoplasm in which a significant component shows hepatocellular differentiation. These are very rare, with only a handful of cases having been reported. They consist of large polygonal cells with abundant eosinophilic cytoplasm, and they can form trabeculae and may even have sinusoidal vascularity. They immunolabel like a hepatocellular carcinoma, so they can have polyclonal CEA or CD10 in a canalicular pattern. They can also express other markers of hepatocellular differentiation like HepR, arginase, albumin, ISH. These are too rare, really, for a meaningful clinical or genetic analysis, but it's important to know that in the pancreas, you can have a primary carcinoma with hepatoid differentiation. They're not all metastases from the liver. Grossly, these tend to be well circumscribed and fleshy neoplasms, having a quite different appearance from a typical pancreatic ductal adenocarcinoma. A low power image shows that these are very pink tumors. They have, abundant granular eosinophilic cytoplasm. They look quite indistinguishable from a primary hepatocellular carcinoma in the liver. They can have areas of pseudogland formation, or they can be more solid. And as I mentioned, these do tend to express markers of hepatocellular differentiation. This is a HepR stain in a hepatoid carcinoma of the pancreas. One important differential diagnosis, though, is acinar cell carcinoma. So these are primary pancreatic neoplasms that can express some hepatic markers, so they can be positive for HepR. So it's important to exclude that with immunohistochemical markers of acinar differentiation, and those should be negative in a hepatoid carcinoma. The other important differential diagnosis to exclude, which I mentioned earlier, is to exclude a metastasis from a hepatocellular primary, especially since primary hepatoid carcinoma of the pancreas is so rare. We'll now move on to talk about medullary carcinoma. So medullary carcinoma is a malignant epithelial neoplasm characterized by poor differentiation, pushing borders, and a syncytial growth pattern. So the same characteristics of a medullary carcinoma of other organs. These also often have prominent intratumoral lymphocytes. And they can be associated with a family history of cancer, in particular Lynch syndrome. These have a trend toward longer survival. So this is a low power view of a medullary carcinoma. The tumor is on the top, and I show this just to demonstrate the pushing borders and the demarcation of a medullary carcinoma, which is in contrast to kind of the insidious glandular infiltration that you see with a standard pancreatic ductal adenocarcinoma. At higher power, these are poorly differentiated tumors. Histologically, you don't see gland formation. They have a syncytial growth pattern where it seems like the cells are all kind of fused together, and they have really prominent tumor infiltrating lymphocytes. And you can see the lymphocytes kind of scattered all through the malignant cells in this case. Here's another example of a medullary carcinoma. Again, poor differentiation, syncytial growth pattern, and then the prominent intratumoral lymphocytes. So genetically, medullary carcinomas can have inactivation of DNA mismatch repair genes like MLH1 and MSH2. This can lead to microsatellite instability, which means that they have hundreds of additional somatic mutations. These are often KRAS wild type, they can have BRAF mutations, and a handful of them have been associated with Epstein-Barr virus. So the reason that the microsatellite instability is clinically important is that these hundreds of additional somatic mutations create hundreds of additional neoantigens that can be targeted by the immune system. And in studies that were not stratified by tissue of origin, the oncology group at Hopkins has shown that microsatellite unstable tumors or tumors with mismatch repair deficiency respond very well to immune checkpoint inhibition and other types of immunotherapy. And so, although medullary carcinomas are uncommon, this association with microsatellite instability suggests that they would respond really well to immune checkpoint blockade. So it's important to clinically acknowledge this group so that they can get the appropriate immunotherapy. And I should mention that the approval of immune checkpoint blockade for mismatch repair deficient tumors, this was approved by the FDA a few years ago, and it was the first approval of a drug that was not targeted to a specific organ site, but targeted to a molecular alteration. So now we'll touch briefly on signet ring carcinoma. So this is a malignant epithelial neoplasm in which the predominant component has infiltrating round non-cohesive cells containing intracytoplasmic mucin. And with a classical signet ring appearance, the intracytoplasmic mucin impinges on the nucleus and creates an indentation. And to call something signet ring carcinoma, at least half of the neoplasm has to consist of signet ring cells. I think most folks here will be familiar with the classical signet ring cell morphology. I'll just show a couple of examples so you can see the crisp vacuole of intracytoplasmic mucin that indents the nucleus and gives it this classic signet ring cell appearance. And here's one more example of that. And just keep in mind that half of the neoplasm has to consist of signet ring cells to call something signet ring cell carcinoma. Now this morphology is quite uncommon in the pancreas, and so it's always important in cases of signet ring cell carcinoma to exclude a metastasis from an organ that more commonly has this morphology, like the stomach or the breast. So now we'll move on to undifferentiated carcinoma. Now, undifferentiated carcinomas are a pretty broad category. It's defined as a malignant epithelial neoplasm with a significant component showing no glandular structures or other features to indicate a definite direction of differentiation. There's really a morphological range in undifferentiated carcinomas. Some of them have pleomorphic, more epithelial mononuclear cells. They can have abundant eosinophilic cytoplasm and some bizarre giant cells. Or undifferentiated carcinomas can be relatively monomorphic with spindle cells, more of a sarcomatoid appearance. These can arise de novo, so a pure undifferentiated carcinoma, or they can occur in association with a mucinocystic neoplasm or a typical PDAC. These are, again, very aggressive neoplasms. The mean survival is only a little bit over 5 months, so they have a very poor prognosis. So I have several images in here just to show you the range of morphologies of undifferentiated carcinomas. This is one, that is somewhat epithelial, but really just has no clear direction of differentiation, and so we classified this as an undifferentiated carcinoma. Here's another with a fair bit of pleomorphism, but no really bizarre giant cells, but again, no gland formation, nothing to suggest epithelial differentiation morphologically, and so we classified this as an undifferentiated carcinoma. Here's one I think that would be classified more as anaplastic, where you have a fair bit of pleomorphism and some scattered really bizarre giant cells. Here's another example of an anaplastic carcinoma. This one was from my colleague, Dr. Liz Thompson. Again, more epithelioid, but these really kind of bizarre giant nuclei scattered throughout. So this is an anaplastic undifferentiated carcinoma. And again, on the other end of the morphological range, they can be more bland and spindle-celled, more of a sarcomatoid carcinoma. And here's another sarcomatoid example. This one is really cellular, but quite bland. This is sarcomatoid undifferentiated carcinoma. And then just one more example of a sarcomatoid undifferentiated carcinoma. So these undifferentiated carcinomas of the pancreas quite commonly lose expression of E-cadherin. And as I mentioned before, they can occur in association with a more well-differentiated ductal adenocarcinoma. So in this example on the bottom, you see the ductal adenocarcinoma component has really nice membranous staining for E-cadherin, and that membranous E-cadherin expression is lost in the undifferentiated component at the top of the image. And the loss of E-cadherin, perhaps not surprisingly, is associated with a poor prognosis. So I want to just briefly mention another subtype of undifferentiated carcinoma, and that's rhabdoid carcinoma. So these have a very specific morphology where they have mononuclear anaplastic cells, prominent macronuclei, and then this very characteristic rhabdoid cell shape. And these seem to be genetically distinct. So about a third of them have loss of SMARCB4, INA1, like rhabdoid carcinomas of other organs. You can also see loss of other SWI/SNF chromatin remodeling components like SMARCA1. The loss of these can be determined by immunohistochemistry with loss of nuclear labeling. So a subset of these rhabdoid undifferentiated carcinomas of the pancreas seem to have a similar genetic profile to rhabdoid carcinomas in other organs. This is really in contrast to the other part of these, which have KRAS mutations and kind of typical genetics for pancreatic ductal adenocarcinoma and have intact SMARCB1. So the rhabdoid undifferentiated carcinoma seems to be a molecularly heterogeneous group. This doesn't have clinical impact right now, but as targeted therapies are developed, it may become important to distinguish the rhabdoid ones with the INI loss from the rhabdoid ones that are just typical KRAS mutant carcinomas. So then the final category of variants that I want to talk about is undifferentiated carcinoma with osteoclast-like giant cells. This is a malignant epithelial neoplasm with large benign appearing multinucleated giant cells admixed with atypical neoplastic mononuclear cells. These can occur as a component of an otherwise unremarkable tubular carcinoma, or they can arise from a cystic precancer, most commonly MCN, or you can have pure undifferentiated carcinoma with osteoclast-like giant cells. The survival data of these is quite variable. There have been reports of a worse survival than typical PDAC, and there have been reports of improved survival. So I think there's still a lack of clarity on the prognostic impact of an undifferentiated carcinoma with osteoclast-like giant cells. Grossly, they tend to be fairly well demarcated, and they can have areas of degeneration. Here's an example of a low power image just showing that kind of strong demarcation of the tumor. And again, these consist of really atypical mononuclear cells admixed with these benign appearing giant cells. Here's a higher power image, again showing the atypical mononuclear cells and the multinucleated giant cells. These can have pretty substantial necrosis, as seen at the bottom of this slide. And you can imagine how this translates into the gross appearance with areas of degeneration and almost pseudocyst formation. These carcinomas can have areas of osteoid formation, as seen here. And as I mentioned, they can be associated with a tubular carcinoma. So in this slide, you can see the kind of typical PDAC component on the right that merges with the undifferentiated carcinoma with osteoclast-like giant cells component on the left. So immunohistochemically, the atypical mononuclear cells variably express markers of epithelial differentiation. So these are the neoplastic cells, and then the osteoclast-like giant cells express markers of histiocytic differentiation, and these are reactive non-neoplastic cells. Genetically, they have the same alterations as typical PDAC with KRAS P53, CDKN2A, and SMAD4, so there's not a genetic determinant of this really unique histological or morphological variant. One important final point is that not all morphologic variants are clinically significant. So I'll just talk through a few that actually aren't clinically significant. Foamy cell change or clear cell change does not impart any sort of prognostic or molecular significance. You can see this change in really gland-forming PDACs that just have foamy or clear cells lining the glands, or they can be more poorly differentiated. One important point here is that metastasis from a renal cell carcinoma primary is not uncommon to the pancreas. So in any neoplasm with this kind of morphology with clear cell change, that should be excluded. But once that is excluded, there's no clinical significance to clear cell change. Large gland or large duct carcinoma of the pancreas also doesn't have any clinical significance. These can be a challenge to exclude from, if the glands are big enough, they can be a challenge to exclude from an IPMN that is a precursor to this carcinoma. You really rely, in this case, on the architecture and determining if these large glands are cysts involving the native ductal system, as you see with an IPMN, versus large neoplastic glands that are involving the stroma in a PDAC. So throughout this talk, we've gone through many of the clinically important morphological variants of ductal adenocarcinoma. These impact prognosis, with adenosquamous carcinoma and undifferentiated carcinomas doing worse than typical PDACs, colloid and medullary carcinomas doing better in prognosis, and then with undifferentiated carcinoma with osteoclast-like giant cells, it's still really unclear what the prognostic implications of this subtype are. And then finally, there are some molecular differences. Somewhat surprisingly, adenosquamous carcinoma and undifferentiated carcinoma